right, so chapter 10, airway management. We've already gone over little bits and pieces of this. We've talked about OPAs and NPAs and suctioning a little bit. We've practiced being able to ventilate the dummies. What I'll tell you guys is ventilating the dummy is a lot harder than ventilating a person. So since you were all pretty good at that, we shouldn't have any worries there when we're actually out in the field really for life, putting our hands on people for, you know, practice and performance of our job. But we're going to talk a little structure. We're going to talk a little function. We'll go over the mechanics of breathing. We'll go over sort of how the whole respiratory system starts and works. And then we will get into chapter 11 a little bit later on, which is pharmacology. I handed out the drug sheets yesterday. You'll probably get one that looks a little different either today or sometime soon. As BLS providers, there's not a whole long ton of medications that we're going to play with, which is helpful and kind of a pain in the neck because it means the ones that we have that we're responsible for, we have to make sure we know them in and out, frontwards and backwards, upside down and sideways. Most of the drugs that we can give as BLS providers are fairly safe. They are pretty straightforward, and there's not a lot of gray area. So that's kind of a nice little bit when it comes to providing treatment for our patients and actually treating whatever it is that they have going on with them. But first things first, chapter 10, airway management. So hopefully those two words at the bottom of the screen look wildly familiar, that external and internal respiration that we've been talking about for a couple of days. It seemed like after the video and with that handout, we kind of got a pretty good idea of the way all of this works. We have the external respiration at the alveoli, between the alveoli and those capillary beds. They call it external respiration because the alveoli are still connected to the outside. So the alveoli, when we take a breath in, they get filled up with oxygen. Gas will always move from high to low. The oxygen in the alveoli is higher concentration than the deoxygenated blood that's close to them. Oxygen moves out of the alveoli, binds onto those red blood cells, the hemoglobin, and goes back to the left side of the heart to be pumped out into systemic circulation. Carbon dioxide moves opposite because the alveoli don't have a lot of carbon dioxide in them. And the deoxygenated blood that's coming from the heart to the lungs has a lot. That's how we breathe out all of that bad air. A lot of this should look familiar as well. We are going to talk structure of the upper portions of our airway. So we have the nasal cavity. The outside and inside of that is what we term the nasopharynx. The nasopharynx is where we're going to put our NPA, measured from the nostril to the earlobe. Just below that, we're going to have our oropharynx. That's where our OPA goes. The biggest source of obstruction at the level of the oropharynx, somebody tell me what it is.
Tongue.
Tongue.
You got it. We have this big muscle that takes up proportionally a large amount of space in our airway. And when our patient is unresponsive, only semi-responsive, not really functioning at optimal level, the tongue can fall to the back of the airway. We don't really swallow it like what people used to think and say years ago, because it's attached in the front. But since it is a muscle, if it's not being controlled by the brain, it's gonna go limp and cause us some problems.
Is that why we prefer to use the OPA over the NPA?
So it's a little from column A, little from column B, right? The OPA is going to be good for when we hear snoring and when we have a patient that's profoundly unresponsive. Gag reflex is the one contraindication to our OPA, and gag reflex is also one of the last reflexes to go away when somebody is like legitimately unresponsive. So it's entirely possible that they're still going to have one and be unresponsive, which is why we kind of draw the line of which one we're going to use.
Okay.
So my chart's not moving if you're moving your screen. It's not. It's still just showing Chapter 10 Airway Management.
That's weird. Hang on, I'll pause it and unpause it and see if that helps.
Yeah, because mine shows the upper airway.
Yeah. All right. Now it's showing it.
Did it fix it?
Yeah.
Hey, all
right.
right. So, a couple of important structures here to take note of. High up on the screen when we're looking in the nasal cavity, most of the air that we bring in from the outside is warmed, humidified, and filtered through our nasal cavity. Up there we have those ridges. You'll see them on the picture. They're called turbinates. Their job is to make the airflow that we take in through our nose turbulent. It will help filter out any particulate. It will help start bringing that air that we're bringing in from the outside up to 98.6 degrees. It will humidify things because our lungs are a moist environment that's body temperature and don't like having all sorts of junk and crud and all sorts of stuff getting introduced down into them. So those turbinates are really, really important. The NPA that we were practicing with yesterday, the reason we put it in with the bevel sort of pointed towards the septum, regardless of which nostril we're going in, is to make sure that we're not damaging these structures. So that's why it's so important that if you're inserting that into somebody and you feel any resistance, it's not, the irresistible force versus the immovable object. If you can't get it to go, stop pushing on it. Moving on down a little bit, we're going to get to the epiglottis. Somebody out there in GoToMeeting world, tell me what the epiglottis is for.
The epiglottis is to prevent any backflow from coming back up.
Okay. For the most part, yeah. Its job is to prevent. Its job is to seal the top of that trachea, airtight, watertight.
Air and food.
Yeah. It's the dividing piece that separates gas that should be going into our lungs and food and drink that should be going into our esophagus. The epiglottis itself, when it clamps down over the top of that trachea, is both gas and watertight. It seals off completely. So the epiglottis, with certain medical conditions, certain problems, think anything that causes like stridor or obstruction, can actually all by itself physiologically create an airway obstruction. We already know a way to deal with that. When we do a jaw thrust to a patient, if we look at our picture here, when we do a jaw thrust, we're putting our fingers pretty much right there and pulling on the mandible of the patient to pull the points of that jaw forward. We can actually get a little bit of space with this epiglottis if it's causing a problem closing off our patient's trachea just by doing a jaw thrust. So if you have a patient who, for one reason or another, you can't ventilate, it might be worth giving a shot to trying to open that airway with a jaw thrust a little bit and see if it's the epiglottis that's causing us our issues. Sooner or later, you kind of run out of tricks and run out of things to do. So throw something at the wall and see if it might stick. Because no airway, dead patient, right? I mean, let's call it what it is. Airway is part of our primary assessment. Airway is one of the initial parts of our primary assessment, and it's in the beginning for a reason. If our patient doesn't have an ability to move gas from out there to in here, we are in some big, big trouble. Now we're getting down lower, we're getting into the lower airway. The lower airway begins when we actually start making our way into the trachea. The trachea is the windpipe. It's the conductive system to get gas moved down to our lungs. So just think of it as like, heating your house, right? Doesn't do us any good to have a furnace if we're not going to have some way to move that warm air everywhere. And our trachea is the way to move that air from the outside to the inside. At the level of the larynx, we have our thyroid cartilage, and right behind that is our vocal cords. You'll start to see in the trachea those cartilage rings. This is a picture of what they look like. Remember, I said they're not full rings. It's about 3/4, and they have smooth muscle on the back. Moving on down, we get to where the trachea.
I have a question.
Shoot.
Now I know we would never do anything, but I'm just curious, where by the larynx would they do a tracheotomy?
So the tracheotomy is just below.
Okay,
So it would be somewhere right around here.
okay.
This picture is probably not really the best to show that, but yeah, it would be somewhere right around where I put the arrow.
Okay, thank you.
Is that for people who smoke and that have bad damage to their lungs?
So yeah, they'll do they call them either tracheostomies or for the most part that's what you'll hear it referred to as, and they actually make a surgical opening in the front of the patient's trachea to bypass the larynx and the voice box and all of that stuff because there's some sort of disease process.
Correct. Would you be able to do a valve mask to that, or?
So we actually have a picture of that being done because, as luck would have it, the end of all of those tracheostomy tubes is exactly the same size as the bag valve mask end. So you can actually put a BVM right on one of those tracheostomy tube ends and ventilate the patient through that. Because if we tried to do just a normal, mask seal to the face, head tilt, chin lift, and ventilate the patient, it would come out through the hole that's in the front of their neck.
Makes sense.
So when we get to the lowermost portion of the trachea itself, that is called the carina. That is where the trachea splits into the left and right main stem bronchus respectively. The left main stem goes off into the left lung. The right main stem goes off into the right lung. And thinking back to when we started in chapter 6 talking about gas exchange, none of that is happening anywhere along this route yet until we get back down a whole lot deeper and make a whole lot more divisions. That left and right main stem bronchi branches off into bronchioles, and those bronchioles branch off even smaller and even more, and they get a little bit smaller and a little bit littler until we actually get out to the separate lobes of the lung. And once we get there, we start breaking out into the respiratory bronchioles and the alveolar ducts, and that's where those alveoli, those grape-like little things, live, and that's where all that gas exchange takes place. Everything between your nose and your mouth and those alveoli is what we'll call dead space. Dead space means it is just space that is being occupied by gas that you have inhaled, where absolutely nothing is happening with it other than keeping the airways open. Not one bit of function is going on until we get down to those alveoli. Looking at our chest here, still in the lower airway, we have left and right lung. The left lung has 2 lobes, the right lung has 3. Somebody tell me why.
To make space for the heart on the left side.
You got it. The heart sits on the left side, just sort of next to the sternum. Well, posterior to and off to the side a little. It doesn't sit dead in the middle of your chest. The left lung has 2 lobes just to allow for some more space for the heart to take up the space that would be the 3rd lobe. The right lung has 3. That's why when we're listening to our patient's chest, we have very specific spots that we're listening to because we're trying to get a picture of what's going on in that patient's entire lung. Now, yesterday when we were talking, I was mentioning those very thin linings over the lung tissue and the inside of the chest wall. It was when we were upstairs in the classroom and listening to lung sounds and all that good stuff. So the lungs are covered in the visceral pleura. Anytime you hear the word visceral, it has something to do with an organ. The visceral pleura is what actually comes against the lung tissue. The parietal pleura is another membrane that lines the inside of the chest wall. Now, those two things are both really, really close together, but they don't actually touch. The reason they're close together is to allow the lungs to be able to expand and contract and move without generating any friction. They allow the lungs to sort of just glide and open up like we want them to, and then glide and close and shrink back down like we want them to in order to inhale and exhale. If anything at all gets between those two pleura, think things like infectious material like pus or gas, so air from the outside, blood, that potential space increases. And now we'll have those two things actually touching one another and actually touching the lungs. And that's when you'll hear that pleural rub. One of you guys described it as it sounds sort of like a chair getting dragged across a hardwood floor. That creates friction. Friction is going to generate heat and inflammation. Inflammation is going to generate pain. And our patient's going to be able to describe that to us. So if you do your breathing assessment, right, when we're doing our ABCs, we always want breathing to be noiseless, effortless, and painless. So if you're listening to your patient's chest and you hear that loud grating kind of noise that sounds like something being dragged, well, it is because something's being dragged. Those two pleura are dragging past one another. And your patient's going to describe it as sort of like an inflammation, almost like a burning type pain. So there, right there, tells me not noiseless, not effortless, not painless, and my patient's respiratory status is pretty well in question at that point. When we get down here to the diaphragm, one of the things that makes this whole system function the way that it's supposed to, which we'll go over in just a second, is that diaphragm. It's a dome-shaped muscular organ that's job is to pull down and anterior, so down and towards the front, to help me expand that chest wall. When we expand our chest wall, we're inhaling. The intercostal muscles will contract and pull my rib cage out. That diaphragm is also going to contract and pull inferior and anterior, so down and forward. And I have now increased the size inside my chest. If we look at the way your chest is actually designed, this is a closed pressurized system. So when I increase that space, I make the pressure inside of that space smaller. That negative pressure causes airflow to go in to try and equalize things off with the atmosphere. Otherwise, we would just explode. So that negative pressure sucks the air in from the outside. We fill our lungs, it gets down to the alveoli, and that's a breath in. We had to use muscle energy to do that. We created that negative pressure by using actual physical energy, which means inhalation is an active process. When we exhale, that whole active process gets reversed. The intercostal muscles, just relax. The diaphragm, same thing. It relaxes, the intercostal muscles relax. We make that space smaller. And if I take this whole closed pressurized system now and make it smaller, what kind of pressure did I create?
A negative.
I created a negative pressure when I made it bigger.
Okay, positive then. That means it's gonna be the
Yeah, I
opposite.
created a positive pressure, and that's what forces all of that gas out. Exhalation, when it is done appropriately, the way that the body wants to do it, is a passive process. No energy being expended. I didn't have to contract or physically move anything. All I had to do was chill out for a minute. And I created a positive pressure inside of that chest cavity, and it forced all of that carbon dioxide out.
So relaxing causes a positive.
Yep, relaxing causes a positive. I like it.
When you're relaxing you're relaxing your diaphragm on that?
Yep, your diaphragm and your intercostals. So
Okay.
it's one of those, like, every action has an opposite reaction. So since I had to use the energy and contract those things and make the space bigger to get gas in, I'm gonna not use any energy. I'm gonna let those muscles relax, which creates a positive, forces all that gas out. We're off and running. Anybody want to go over that again, or was that
Yeah,
straightforward
Tom.
enough?
Quick question with the negative pressure causing us to take in air.
Yep.
I'm just a little confused with that whole verbiage on the negative pressure causing us to take in air. Is it because there's not enough?
I think what might make it easy, Tom, correct me if I'm wrong, but I think I read somewhere that when you breathe in and the muscles are being active like that it's a vacuum.
Yeah, it's definitely creating a vacuum.
So I guess,
And
Jonathan, you can look at it like a vacuum is sucking, so it's pulling in a negative, it's making a negative pressure.
There's too much in there.
So there's too much space.
Too much space causes the negative pressure.
Yep. So when we're talking the differences in pressure, right, we're talking it measured against the atmosphere. So if you think of it like a vacuum, or just think of, if anybody watched the show Hoarders?
Yeah.
Oh yeah.
All right. So they have all of this stuff in a small space, and it looks ridiculous, right? But if you got a space now that was twice as big, you would need to bring more things in to fill that space. That's exactly what's happening there. So we made a space bigger, we need more stuff. So the pressure created when I make that space bigger causes a negative thing to happen. Negative pressure draws all that gas in. Negative personal pressure will cause you to fill a bigger house with twice as much crap.
Makes sense now. Thank you.
That make it any better, Jonathan?
Oh yeah.
Did we lose them?
No, I'm here.
All right. So you get what I'm saying? If we make the space bigger, we have more space for stuff. The pressure differences really might make a little more sense when we talk about when we ventilate a patient with a BVM, right? That's called a positive pressure ventilation, because I'm actually forcing something into that person, right? When I make a seal on their face with that mask and I squeeze the BVM, I'm really kind of shoving gas into them. Physiologically, when you think about it, it's not really that much work and that much stress on your body to just get air in. Air just sort of flows in naturally, right?
Yep.
That's why that's caused by a negative pressure. The vacuum, thinking about it as a vacuum, was probably like one of the best ways to sort of take a peek at that. You know, more space is going to require more things to fill it, which is why the gas just flows in sort of all on its own.
Okay.
So most of this stuff that we do as far as respiratory and ventilatory goes is not something we have to think about. It is controlled by our nervous system. Our nervous system is constantly working to make air go in and out and blood go round and round. That's really what the job is. We have all sorts of respiratory centers in the brainstem that will control taking a breath in, exhaling, how deeply, how quickly, the rhythm, you name it, that's what they're there for. Throughout the body, though, we have these things called chemoreceptors. Those chemoreceptors are responsible for responding to second changes in the levels of carbon dioxide and oxygen in our blood. Because we know carbon dioxide is what we breathe out, right? That's the bad air we're trying to get rid of. Normal, healthy people, their respiratory cycle, so the whole out with the bad air, in with the good, is triggered in just that way. Our respiratory cycle actually begins with exhalation, not inhalation, because these chemoreceptors pick up on minute changes and increases in carbon dioxide inside our body and want us to get rid of that. So it stimulates us to blow that carbon dioxide away. That's called hypercarbic drive. So hyper is high, carbon dioxide, IC or IA is in the blood, high carbon dioxide in the blood triggers us to exhale. When we see people who have, smoked for 125 years or have some other respiratory pathology going on, we will see people switch from that hypercarbic drive to hypoxic drive. Their body responds to, I can't get enough oxygen right now. I need to work harder. Because remember, looking at inhalation and exhalation, inhalation is an active process. Exhalation is a passive process. So our normal functioning human, all of us, our body's saying, we got too much carbon dioxide. Why don't you blow some of that away? And our muscles just relax and create that positive pressure inside of our chest, inside of the vacuum that our chest really is, and blows off that carbon dioxide. People who are unhealthy and have some significant respiratory compromise, they're stimulated to breathe by, we don't have enough oxygen. We need to breathe faster. We need to get more oxygen in. And you'll see they actually respond to not having enough oxygen in their blood. And that's called hypoxic drive, hypoxic drive. Hypo is low, ox is oxygen. IC, again, means in the blood. IA means in the blood. So we have low oxygen in the blood. And all of those chemoreceptors will pick those signals up. And when they do, they'll send off to the nervous system, hey, exhale more, inhale more, breathe faster, breathe this, breathe that. And the brain sends off its messages from there and stimulates all of those muscles of respiration to either work different, work harder, or work faster. And we can actually physically see that in our patients when we're seeing things like increased respiratory rate or changes in their respiratory pattern just based on really looking at them. Add to that now the rest of our primary assessment when we're talking about things like skin color, temperature, condition, and how well are they actually supplying oxygenated blood. And it really kind of pulls the whole thing right together and tells us, how is this patient doing? And we really haven't even touched them yet. So how are we doing? Is anybody not following this? Any of the stuff we've gone through so far here this morning, you guys want me to go over again?
I guess one question on, so again, when we inhale and our chest expands, that's contracting and our diaphragm pushes downward and gets smaller and goes towards the interior of our body.
Yeah, it doesn't really get smaller when it sits at rest in our chest.
Mm-hmm.
It's shaped like a dome.
Okay.
When it contracts, it pulls down and sort of flattens out and pulls towards the front. It doesn't really change in size. It more just changes in the way it
Direction.
looks.
The way it
Yeah,
looks.
direction. Direction works.
Okay.
And
So
if we,
that makes the space to bring in more oxygen.
yep.
Okay.
If we do, I like the idea of just thinking it as a vacuum.
Yep.
If we increase the space but keep the vacuum, we make the pressure negative. If we decrease the space but keep the vacuum, we make the pressure positive, and that's what forces things out of it.
Okay.
So could you think of the BVM as like a manual bypass for a diaphragm?
Yeah. And it is 100%, and however you guys can file this away and remember it, it is sort of like a bypass. Like we'll have to ventilate sometimes spinal cord injury patients because their spinal cord has been injured so high up that the nerve impulses don't even get to the diaphragm anymore. So they are physically 100% unable to breathe on their own. And we will bypass that whole problem by just using a BVM to ventilate them.
So a lot of patients maybe going forward in the future with our practice, if they had any type of spine injury in the C column area, that would most likely would affect their diaphragm when breathing.
Yeah, it depends on how high up it is. When we talk about spinal cord injury, the higher up in the spinal cord it is, and especially when we talk about the cervical vertebrae, the higher up in the C-spine it is, the closer it is to the most important functions, and the most likely it is they're going to have some like hugely significant issues.
Okay, thank you.
Yeah, no problem. So we've been talking about oxygen. We've been talking about carbon dioxide. This is just another picture of what we watched on that video and what I handed out yesterday. We are right here down at the cellular level because we have oxygen and nutrients being delivered to the cells right here. So that means these cells have a low concentration of oxygen, and the blood has a very high concentration of oxygen. So my oxygen and nutrients go in, my carbon dioxide and waste products go out, and then the blood, as it's trailing off our picture here, is headed on its way through systemic circulation back to the right side of the heart for the whole cycle to just continue. It's going to go round and round and round we go. Hypoxia is just an inadequate amount of oxygen being delivered to the cells. Because if we aren't delivering this like we're supposed to, all of this stuff here is just going to build up because we don't have that gas exchange. And if we don't have that gas exchange, these cells are going to begin to have problems. They're eventually going to get to the point where they will actually just explode and die, and we'll have entire pieces of this person, depending on how significant the hypoxic event is, really start to have some pretty negative issues. The brain is the one that jumps to mind the most, because most of the more resilient body tissues, if they get their oxygen delivery interrupted for a little bit, they're going to come back around. Eventually, when perfusion or oxygenated blood is restored to those cells and restored to those tissues, they're going to be okay. The brain won't switch and create energy. The brain, if it does not have constant and continuous oxygen and glucose being delivered to it, those cells are just done. That's that anaerobic and aerobic metabolism. Aerobic cellular metabolism means those cells are creating energy in the presence of oxygen and glucose. So if we take this away and we're saying, all right, we're in the foot right now. The cells of your foot can stand a little bit of oxygen deprivation. They can stand a little bit of buildup of all of these waste products and even more waste products that are created with anaerobic metabolism. Now, if we were in the brain instead of the foot, this oxygen deprivation is going to cause your patient to be altered almost straight away. And as soon as that starts to happen, your patient is going to start getting to the point where brain damage or brain death is very likely. Inadequate breathing can cause all of this. So if we start thinking about things like our opiate overdose patient who's only breathing 4 times a minute, our asthma patient who is trapping all of that CO2 and can't get any of the good air in, you can think of a million different things that will cause this problem to actually start to present itself to us as providers. And at the base of it, whether it's an overdose, whether it's an asthma patient, whether it's a stroke, whether it's an injury to any of the respiratory structures or the mechanics of breathing, they're all going to show us the same problems. They're all going to present as, my patient is hypoxic, my patient isn't getting enough oxygen. And that's kind of a blessing and a curse, because sometimes we never really get to figure out what the hell it was that was causing the problem. But let me ask you a question that takes that a little bit further. How much does that really matter?
Not really.
It's not a huge thing. What's more important is our recognition of and response to what the actual problem is. If you look at somebody and see them doing this kind of stuff, what do you think tachypnea means?
Is that
Breathing?
Fast breathing.
fast breathing? Yeah.
That's fast breathing. Tachypnea.
Tachypnea.
Pnea means breathing. Tachy
Yep.
means fast.
Is it bradypnea, which is breathing too slow, below the normal
Yes,
level?
sir. That is a slow respiratory rate. And then that next one, dyspnea or dyspnea. We know what the suffix of the word means, or the root of the word is. What do you think that DYS means?
Shortness of breath.
So yeah, it's what we would call shortness of breath, but dyspnea normally would just be termed sort of dysfunction of or difficulty with. So shortness of breath will be the catch-all for it, but it just sort of means not right? Having a problem with. We have pale, cool, clammy skin. That tells us a whole bunch of important information, right? What's not getting out to the distal portions of the body if when you show up, your patient is pale, cool, and clammy or diaphoretic instead of pink, warm, and dry?
Oxygen-rich blood. Sorry.
Yeah, we're not getting oxygen-rich blood delivered to everywhere that we're supposed to, so the body has started to shut things down because your brain's going to decide early on in this whole problem. This is why this is sort of mild and moderate hypoxia. You'll see what gets a little later here in just a second. But that pale, cool, clammy skin means the brain has decided that all the places that aren't important aren't going to get a blood supply right now. Or if they are, they're not going to get much. Why do you think our heart rate will go up? Tachycardia.
It's trying to rush to get the blood to where it needs to go.
Yeah, if we're going to speed up the breathing, we better speed up the heart beating too, because we need now to pump that oxygenated blood around faster. Restlessness, agitation, and then a little bit later, disorientation and confusion. Why do you think we start to see some changes in our patient's mental status?
Less oxygen to the brain.
Yeah, if the brain's not getting supplied, it's going to start to malfunction real early in the game. And then we get to severe signs of hypoxia. Now, if you look, you'll see some of these are pretty similar, right? We have tachypnea, so we're breathing fast. We have dyspnea, so we have some respiratory difficulty or respiratory distress. We have tachycardia because the heart rate is still gonna continue to try and climb to meet that demand. But then look at the change in skin color, temperature, and condition we found. Cyanosis. Does anybody remember what that is?
Blue underneath the eyes where it should be pink, or around the lips where it should be pink.
Yeah, we start to see our patient turning blue. So let's go back one slide. We'll talk pale. In the grand scheme of things, can we just make the argument that pale is much better than blue?
Yes, sir.
All right. People are not supposed to be blue. If your patient is blue, that's the problem jumping up and waving at you saying, hey, I'm sick. And then we start to see a bit more changing in my patient's mental status. They go from just a little restless, a little agitated, a little nervous, to now we're actually going to call them confused, or their mental status is altered.
So could we say that the pale, cool, clammy skin is a warning for what's to come?
Yes, sir. That pale, cool, clammy skin is absolutely your patient warning you that, hey, I'm not doing well. Now, it doesn't always mean respiratory. It doesn't always mean cardiac. There's a bunch of different things that can mean, and believe me, we'll talk about all of them. But pale,
like
cool, clammy is
like-
better than anything else. It is one of the initial things we're going to look for, which is why we assess for it so early. This head bobbing one, this is pretty much where we're going to draw some pretty significant lines here. So your patient, when we talk about head bobbing, this is a patient who almost looks like they're falling asleep between breaths. So as they're exhaling, since their body's just relaxing, it's like they're nodding off. And now let's quantify this. This is not an opiate overdose we're talking about. We're strictly respiratory right now. So this is a respiratory patient who breathing has now become so much work and become so physically taxing and so labor intensive that they're actually falling asleep from doing it. When we start to see somebody going from these moderate signs here and, not looking great, but still holding their own, to now really looking like crap and looking like they are starting to fail, right? All of this stuff on the severe hypoxia slide, that looks like somebody whose body is beginning to give up, right?
Yeah.
That's because it is. So our signs and symptoms of moderate hypoxia, that's going to be our respiratory distress patient. Our signs and symptoms of moderate hypoxia is going to be a patient that we can just put that non-rebreather mask on and let them breathe in some 100% oxygen, and they will probably, at least for a time, get better. Our patient who's already showing us this kind of stuff is not going to get better on their own. They are not physically going to be able to breathe appropriately enough to now turn this around. Our patient who's showing us some of these signs of severe hypoxia, this is the patient we're going to ventilate with a BVM, because this right here is the clinical definition of respiratory failure. This is a patient whose body is failing to meet its own physical and metabolic needs, so we have to do it for them.
Does moderate hypoxia always turn into severe hypoxia if left untreated, or can some people just stay at that?
So some people just are an outright train wreck as far as respiratory goes, and we'll see, with our moderate hypoxia patient, right? That could be somebody who's got congestive heart failure, and on exertion, they get really dyspneic and really tachypneic, and they really start to not do well. But all they have to do is sit down and relax and catch their breath, and they come back around. This is always something that's going to require your intervention. Sometimes people that just don't have a particularly strong respiratory status, they will get short of breath, start breathing a little fast, and as long as they stop what it is that they're doing and take a few minutes, they tend to get a little bit better.
So we're always going to see more difficulty with patients that are consistent smokers.
Yeah, smoking's one of the big ones that causes, and that's some of the stuff we're going to talk about, I think, on Monday with the respiratory lecture, or maybe Tuesday, I think, actually. And we'll talk about, some of the causes for a lot of the respiratory issues we look at. Yeah, smoking's one of the big ones. So let's ask one more question here before we head off to the break. Let's say we're here and we're seeing someone who's breathing really, really fast, and I'm talking just ridiculously fast. They were cyanotic when we showed up. They were tachycardic and confused. And as we're working our way through our assessment and trying to get a handle on what's going on, because we think they're in respiratory failure, the confusion stays the same, but their heart rate starts to go down and their respiratory rate starts to go down. They're still cyanotic, and maybe you're ventilating with a BVM, maybe you're not at this point. Did they get better?
Yes.
Still cyanotic.
All right, I heard they're still cyanotic.
I mean, they're getting a little better because their blood pressure is going down instead of going out the roof. But I mean, they're still in a dangerous stage. It could be possibly choking on something if the oxygen's not getting delivered still.
So if the confusion's going down,
ventilating with a BVM, we probably don't have an airway obstruction. But let's just look at this for one more second and say, how fast do you think their respiratory rate and heart rate can get before it starts turning around and coming back down? Do you think it just will continue to increase and increase and increase and increase and increase? Or do you think it eventually hits a stopping point regardless of whether they got better or worse and starts heading back down towards zero?
Yeah, I feel like at this point, I'd be worried about like failure, like respiratory failure. If that could be a sign of it, and I could be wrong.
Yeah, we're for sure in respiratory failure at this point. But if you are treating somebody in this state, let's say you are ventilating them with a BVM, and you start to see their tachypnea going back down to what you would consider a more normal and reasonable level, and their tachycardia doing the same thing, but their cyanosis isn't improving, they are not getting better. They are actually getting ready to go from respiratory failure to either respiratory or cardiac arrest. Because pretty much throughout this whole thing, they should be breathing fast because they're trying to take in more gas. They should have a rapid heart rate because they have to try and move around that more gas faster. But if we don't see these things starting to improve, the cyanosis, the altered mental status, if those things aren't improving, even when we are ventilating the patient with a BVM, even if we see their respiratory rate come down and their heart rate come down, they're not getting better. One of the things we'll see when they start to get better is maybe they relax some, and maybe they start to not look like they're working so hard because we're taking all that work off them with the BVM. Eventually, they'll start to pink up a little bit, and maybe after some time, their respiratory rate and their heart rate will get better. But if you're ventilating them and you still see cyanosis and altered mental status, get ready because they're going to just stop breathing at some point. The body will eventually get to the point where all of this becomes so much work and so much energy expenditure that it just quits. And that's when we go from shortness of breath to respiratory failure to respiratory arrest. Arrest means lack of. So lack of respiration. How are we doing so far?
Good.
All right. We're going to get back into this picture in just a minute, but before we get moving on to stuff that's going to give you guys a headache, we're going to take another break. So I'm putting 10 minutes on the clock. Take yourselves a short break, get some more coffee, and when we come back, we'll talk about our external and internal respiration again. All right, gentlemen, we are back. So now we're talking about that external gas exchange. This is just a different look at the picture that we had yesterday. This is going to be our alveolar capillary gas exchange. We just filled those alveoli up with a deep breath in. And that means those alveoli have a lot of oxygen. We have a high concentration of oxygen in the alveoli. This blue blood here just exited the right ventricle, came in through those pulmonary arteries because arteries travel away, and it is deoxygenated. This is blood that has already delivered its oxygen to the cells. So we have only a small concentration of O2 here. We have a high concentration of CO2 here. And what we know about gases is gases will always move from high concentration to low. So our carbon dioxide is going to move from its high concentration to its low concentration. Our oxygen is going to move from its high concentration to its low concentration and out into the bloodstream. And where is that blood going back to now? Once we've oxygenated that blood and it's ready to go off and do its job again, which part of the heart is responsible for that?
Left part of the heart.
The left side of the heart. You got it. This blood here is now going to enter those pulmonary veins. It's going to be transported to the left atria, down into the left ventricle. It's going to get pumped out through systemic circulation. And we're going to have mostly the same picture here because now we're getting down to the cellular level and our internal respiration. This is newly oxygenated blood from the left ventricle getting pumped out to all points of the body. We have a high concentration of oxygen. We have a low concentration of CO2. When we get to the cell going to have a lot of O2 or a little O2?
A little bit.
Little O2.
A little bit. What's it going to have a lot of?
A lot of oxygen.
CO2.
A lot of CO2. So that oxygen-rich blood is going to deliver that oxygen to the oxygen poor cell. The carbon dioxide in the cell, since the cell is carbon dioxide rich and the blood is carbon dioxide poor, we're going to transfer that carbon dioxide out through diffusion. And we're going to go back into systemic circulation with this carbon dioxide rich blood now. And we're going to wind up right back here from the right side of our heart to the alveoli to just wash, rinse, repeat, and do it all over again every heartbeat and every breath of your entire existence as a person.
So those cells were constantly trying to get oxygen in there and get rid of the waste products.
Yep, constant. It is a constant need for oxygen to create energy and blood to transfer the oxygen and carbon dioxide to and from. And as long as blood is continuing to deliver the oxygen, diffusion is going to make it always remove the carbon dioxide, and our metabolic machine, our person, is going to just keep right on keeping on, because at the end of the day, all those cells want is that oxygen. That is what they are constantly hungry and hunting for.
So, quick question. When you have the anaerobic metabolism and you start getting that buildup of lactic acid in the cells, after you restore oxygen into them, where does that acid go? Or does it just get filtered out later?
It gets filtered up. It gets filtered out. It gets picked up. One of the problems with anaerobic metabolism and all of that acid and the lactic acid and the pyruvic acid and all the other crap that is created through anaerobic metabolism is that when it gets into systemic circulation, it's poisonous. When you hear about people getting pinned against something, it happens a lot with maybe, not motor vehicle collisions, but workplace accidents. Somebody's working on a car and the car rolls against them at the waist and pins them to the wall. Well, everything below where that car has them pinned, if circulation is stopped, half of their body has switched to anaerobic metabolism. So they may still be conscious, alert, oriented, have a heart rate, have a good blood pressure, because all of their vital organs are getting that oxygenated blood supply. Their brain is still being perfused. Their heart and their lungs are still being perfused. But south of the border, we have that whole anaerobic metabolism process taking place. So when we move the car, a lot of times those people immediately go into cardiac arrest because all that stuff that's building up from anaerobic metabolism is poisonous. And when we introduce it to the rest of the body on a high scale, people wind up dying almost immediately. Because the byproducts from that anaerobic metabolism are highly poisonous to the rest of the cells.
And you said those cells will explode?
Yeah, they eventually that acid just rushes right into the cells. They explode, they spill their contents, which are also acidic. So more cells do it, tissues do it, organs do it, and then sooner rather than later, the person does it too. So what I can tell right now is from the question that you guys are asking, the questions that I'm getting with this stuff is you're getting it. Even if it doesn't feel like you are. Congratulations there. And when we talk about shock the beginning of next week, this kind of ties all together with that. And you're going to start it's going to start feeling like it makes sense. So if it doesn't feel like this means anything at the moment, we'll get there. So this is a pretty intricate process. All of this stuff has 1,000,001 different ways that we can see disruption, see dysfunction, and have negative things cause negative outcomes. The easiest ones are mechanical, right? Mechanical just means the actual mechanics of breathing aren't working appropriately. So we talked a little bit about that already with a patient who has a high cervical spine injury. If their brain can't get the message to the nerves and muscles and functional pieces that are supposed to contract my intercostal muscles and expand my chest wall, contract my diaphragm, and make that negative pressure inside my thoracic cavity vacuum, then the mechanics have broken down, and that's when we're going to be ventilating the person. We can also see things like our asthma patient who has the constriction. The mechanics of that have now clamped off a lot of that lung tissue and made it difficult / impossible for our patient to actually physically, mechanically move any gas. The mechanics are the easy ones to fix, because if we have a mechanical problem, generally it requires a mechanical solution. We ventilate the patient with a BVM, we supply more oxygen to them, and it starts to fix a bit of the mechanical process. It starts to fix a bit of the hypoxia, and it starts to sort of turn the corner for these patients. Disease process is a bit more difficult, because if our patient's respiratory system is diseased from pneumonia or emphysema or congestive heart failure, we're not really fixing the disease. What we have to do when it is a disease process that is causing our patient's airway and respiratory status to be questionable at best is treat the signs and symptoms. We are treating the things that we see. We are treating the patient's complaint, because most of those are going to be respiratory distress, shortness of breath, tachypnea, tachycardia. And the way we fix those is, again, with some oxygen and some ventilation, or maybe even some medication, because asthma is another of the disease column too. Asthma as a lung issue is difficult to treat. Most people with asthma, if they need to call 911, they wait too long to call 911. A lot of the times, the Inhaler isn't always, especially if they're short of breath, isn't used correctly. So they don't get the amount of medicine that they think they're getting. And we wind up seeing the disease process itself causing a problem and the mechanical disruption of those alveoli causing a problem. And the more problems we start stacking up against us, it makes sense that the condition itself becomes a bit more difficult to treat. Now, we talked about obstruction when we did the American Heart Association class. Obstruction doesn't always mean foreign body. Obstruction can mean, yes, they're choking, and their choking has become a disruption to their ability to move gas, and we have some issues there. We talked a little bit yesterday with a couple of the groups about things like tension pneumothorax and how that creates an obstruction. We'll get into that real deep real soon, Monday, I think. But just know that obstruction can come in many forms. It doesn't always have to be that they're choking on something. If something obstructs blood flow and the ability to refill the heart, or if something obstructs blood flow and the ability of blood to be able to get from the heart to the lungs, we're going to see some hypoxia. It just has to be that way. Because if the lungs can't oxygenate the blood, or the heart can't pump the blood to be oxygenated, or the heart can't pump that oxygenated blood to the cells, the end result is always going to be a lack of perfusion, so hypoperfusion, and hypoxia. So if we know that oxygen delivery and oxygen in general is the problem when it comes to hypoxia and hypoperfusion, what do you think the treatment is?
Oxygen or ventilations.
Bingo. Oxygen or ventilations. It just depends on how sick the person is. There's your two options. If we know hypoxia and we know hypoperfusion, the problem with those two things is either lack of oxygen or lack of delivery of that oxygen. The solution is simple. The things don't always have to be like high level and confusing. I know that I probably sound like a jerk saying that because most of the stuff that we've talked about for the last week has been high level and friggin' confusing. But sometimes the solution is every bit just as simple as it seems like it is. If the problem is oxygen, the solution is oxygen. So we talked about the differences in airway anatomy with children and adults. This is sort of review here. Let's take a look first and foremost at our adult. We know moving down, we'll start in the trachea. We know that those cricoid cartilage get more rigid as somebody gets older, and it gives their trachea more structure, and it makes it less floppy and less problems with positioning. An adult, we can extend their neck and do a head tilt chin lift, no problem, and we are not going to collapse their trachea. What happens if we extend the neck of a child too much?
You crush the lungs.
Block the airway.
Yeah, we block the airway. Because just from positioning the airway a bit too aggressively, we've now pinched it closed. Some of the other things we're looking at here is if you look at the size of, and these are drawn to scale, the size and proportion of a child's tongue to the size and proportion of that adult's tongue, it takes up more space. So when we talked about the OPA, we talked about the fact that the OPA is going to be our go-to device to clear those snoring respirations and to correct that. With a kid, it's an even more likely problem because the tongue just physically takes up more space in their airway than it does in the airway of an adult. When we talk about the size and shape of their head, kids' heads are proportionally larger in relation to their body than adults are. And we can have now hyperflexion of their airway, and their own body can actually cause an airway obstruction. Do you guys remember what it was I told you to do to fix that?
For children,
Yeah, for children.
you put like a padding underneath their shoulders or your thumbs. I mean your hands.
Yeah, you got it. We're just going to pad something in between the shoulder blades to put them into that neutral sniffing position. Kids, you can almost ventilate with one hand if they're in that sniffing position. You almost don't even really have to really mush the mask down onto their face. It's very, very simple. Even the dummies are very easy to ventilate if you put them in that sniffing position because it just lines everything up perfectly. So let's talk airway assessment here for just a couple minutes. When we mentioned and did our lecture yesterday on primary assessment, what did I tell you that an airway needs to be in order for us to call it patent?
Clear or open?
2 out of 3. You got one more in your bag of tricks?
Secure.
Bingo. So the airway needs to be open, clear, and secure in order for us to actually call it patent. Now, as long as your patient is able to speak to you and isn't making any crazy stridorous noises when they're doing so, your patient has a patent airway. Because normally functioning humans that are conscious, alert, and oriented, who haven't just come out of a fire or a chemical inhalation or something like that, their airway is going to be patent just by the fact that they are conscious. Conscious people maintain their own airways. We don't have to do it for them. Now, our patient who is altered in any way is not maintaining their own airway because they are not functioning normally mentally. Their body is not doing the things that a body is supposed to do to keep them a conscious, alert, and oriented human. So we need to make sure that we keep that airway open with either a head tilt, chin lift, a jaw thrust, some positioning maybe in that left lateral recumbent position. Clear. So we mentioned yesterday some suction. If we hear gurgling sounds in our patient's airway, we're going to use a suction catheter to get all of that stuff out of there, and then we can call the airway clear. If our patient is vomiting and they have vomit left in their airway, we have to go ahead and get that out, position them a little, suction, maybe use the suction catheter as kind of a scoop to get the chunky bits out.
On suctioning, sir, there should be a time limit, correct?
There is indeed. When we suction a patient, we want to suction for no more than 15 seconds, and we always suction on the way out, not as we're introducing the catheter. If you apply suction as you're putting the catheter into somebody's mouth, you actually wind up pushing some of the stuff down a little further. We never want to suction any further than we can see, and we apply the suction as we're getting ready to withdraw the catheter, because we're trying to avoid at all costs pushing stuff any further down. We only want to get junk out of the airway. We don't want to push it further into it. And the one thing I mentioned was a patient who was conscious, alert, and oriented, but had all sorts of stridor coming from their upper airway. Why would I not say that that airway was patent?
It's not
It's
secure.
compromised.
Ooh, I heard not secure and compromised. I like both of those. Tell me why you would say that it's compromised and not secure.
I guess since you said they had stridor, they took in some type of smoke or something to interrupt everything.
Yeah, what's going on? What's all that smoke and heat and all the other causing?
Esophagus.
So we're talking some burning, and burning's going to cause swelling. And if we go back to our airway picture, this isn't the greatest one, but it's good enough. Does it look like there's a whole lot of extra space in there?
No, not at all.
Yeah, none at all. You're right. So we start to see some swelling, and we start to see some inflammation and some irritation. And all of that swelling is making these tissues poke out and get bigger. What's that doing to the size of my airway?
It's making it decrease.
Restricting it.
It's restricting it and making it smaller, up to the point where it may actually do this and close it off altogether. So if you hear any we call them adventitious noises. Adventitious just is a fancy $10 medical word for wrong. If you hear any airway noises coming from your patient that don't sound like noiseless, effortless, and painless, or don't sound like, you know, the smooth movement of gas that we're supposed to have in a secured airway, you have an airway that's not patent. Because anything that threatens the security of that airway, whether it's corrected with an OPA or an NPA, or it's uncorrectable at the BLS level, and we know that we have a patient whose airway is trying to close on us, it means just by definition that that airway is no longer patent. We are in a bad neighborhood, and it's time to get transporting. All right, so we talked about lung sounds a lot, and I played some lung sounds, and some of these should look very, very familiar. We have snoring, crowing, and gurgling, and stridor. So what's causing my snoring sound?
Your tongue obstructing the airway
Tongue, yeah. How do I fix it?
by using an OPA.
Depressing it.
Absolutely. Then I have gurgling. What's causing gurgling?
And a liquid.
Fluid.
Liquid in the lungs.
Yeah, well, more in the airway than the lungs, because in the lungs we're going to hear crackles, right?
Oh, yeah.
So
Okay.
how do I fix gurgling?
Suction.
You got it. And then we have stridor. Stridor, we just covered what the cause is going to be. Is there anything we can do to fix it? Not a trick question, promise.
I'll take a shot.
No, you could maybe try to make it better, but I don't think you can fix it, especially if it's like a burn or something.
Yeah, realistically, any of the things that we're going to do to try and make it better, more likely to make it worse than anything else. Your stridor patient is a patient who has, hands down, one of the scariest airway problems that we're going to see. Because at any minute, that airway can go from unsecure to unmanageable. So your patient, when you hear things like stridor, needs immediate transport. This is not something that we're going to play with. This is not something that anything that we're going to try is going to be successful. This is definitely one of those times when you hear that noise that you want to absolutely request to be intercepted by a paramedic, because this patient could need to be intubated or have a surgical airway done at any moment. And this is not one of those like, hey, this will be all right. I assure you this will not be okay. So pay close attention to your airway noises. Crowing is kind of like stridor in the fact that it is restriction in the airway, but it's a whole lot less severe. Crowing is a restriction of air going out, not air going in. So it's more a muscle contraction narrowing the opening of the trachea. So it's more something we'll see in like almost like whooping cough or more children. This isn't structural damage. This is just sort of spasming of the muscles from some constant aggravation and irritation, like a chronic cough. Crowing does not have the same sort of negative connotations as stridor. They tell you that crowing sounds sort of like the noise of the bird a crow makes. Stridor is a much more harsh noise, and stridor oftentimes is heard on inspiration. So we hear it when our patient's taking a breath in, not trying to blow a breath out. So there's the difference between the two of those. And just know that stridor is negative good for all parties involved. So we hit this pretty quick. Suction is necessary. Suction is something that we are absolutely going to have in our toolkit, and it is something that we are going to use. And know that when you are suctioning crud out of somebody's airway, it is definitely got the opportunity to get things that are gross all over you. So this guy having his face mask and eye shield on is not an overreaction. If you're going to be messing around with somebody's airway, it's a good idea to protect your eyes. I have had a workplace exposure because something got splashed in my eyes. It's not a fun time. It would have been much better off to just an ounce of prevention over a pound of cure. I'll assure you of that. What he's holding in his hands right there is what we call a soft tip suction catheter, or a French catheter. We have a couple of different pieces of equipment that we're going to use. Attached to the inside of your ambulance, this is on the wall. This is the fixed or in-house suction. The canister on the right-hand side there is the canister where all of the chunky bits are going to wind up, all of the blood, all of the liquid portion of the vomit. Whatever you suction out will go into that can. When we look at the next picture on our portable suction, you'll see how it all works. This too works as a vacuum. You have the suction unit on the right-hand side there. You have your collection bin, and then you have these two little caps here. We have a cap there, and then if the suction tubing wasn't connected, you'd see a cap there. As long as all the holes on this piece of equipment are plugged, you'll get suction out of the end of your suction tubing. So if you hook your whole equipment up and find that you put your hand against the suction tubing and nothing's drawing back on you, you're not getting any vacuum, it just means you have a leak somewhere. Once you connect the suction tubing to the suction unit, we have a couple of different catheters we can choose. The first one we're going to talk about is our rigid tip suction catheter, or our Yankauer suction. This is just what it sounds like. It is a hard plastic suction catheter. On the handle, right up here somewhere, generally there is a hole drilled in this piece of equipment. That's so that when we put the suction catheter in our patient's mouth and get ready to suction, we're only suctioning on the way out. You put your thumb over that hole, you complete the circuit, and now you have vacuum, and you can go ahead and get all the crud out of that patient's airway, suctioning no further than you can see for no longer than 15 seconds.
Patients may require suctioning because of secretions, vomitus, blood in the airway. We can use a portable suction or one of our on-board suctions on the back of the ambulance. For demonstration purposes, I have removed this from the bag in order to show you the parts of the portable suction. Suction tubing, suction catheters like the Yonkers or rigid tip, or the soft tip catheter seen here can be used. These are the disposable portions of the suction unit. Portable suction unit has a container that will hold the secretions, vomitus, as well as a battery and a switch that will allow the suction to be turned on. I will first demonstrate the Yonkers rigid tip suction catheter. In order to utilize this device, we must also measure. Similar to that of the oropharyngeal airway, we measure.
All right, that guy's awful.
So it's like being at the dentist.
What's that?
It's like being at the dentist.
Yeah, it is. It's just like that. Next, we have our soft tip or flexible French catheters. And looking at both of those pieces of equipment, you can see that the diameter of the end of it is not very big. Our suction equipment is pretty decent at being able to get fluid and mucus and watery type things out of a patient's airway. If you are looking at cheeseburger in your patient's airway, this is not going to be successful. We may use that as a scoop a little bit to get that out of our patient's airway. We may actually disconnect the suction catheter altogether and use the wider bore of the suction tubing itself to clear out our patient's airway a little bit. Just remember, rigid tip, French tip, only 15 seconds, no further than you can see. Those are the things that we need to know about suctioning. There we're using the cross finger technique. Don't get the tips of your fingers bit off. One of the things that we can watch for when we're suctioning a patient is someone should be checking the patient's pulse if there's time and opportunity. If your patient's heart rate starts to go down, you need to stop suctioning them because we are actually causing that with the suctioning. So even if you haven't gotten to your 15 seconds, if your patient's heart rate starts to drop, stop suctioning and come up with something else. So when we're assessing our patient's breathing, I know we talked about this some yesterday during our primary assessment. We're using a whole bunch of our senses here. Look, listen, and feel, and we're going to auscultate our lung sounds. Auscultate, $10 fancy medical word that means use your stethoscope and listen. First things first, without ever getting handsy with the patient, we're just gonna look. We're looking at the chest. We're trying to observe chest rise and fall. We're looking at their pattern of breathing. Remember, noiseless, effortless, and painless, and rate, rhythm, and quality is what we're looking for when it comes to our respiratory assessment. So as I'm looking, I can look and see, how is this patient breathing? Are they using all sorts of crazy additional muscles to accomplish the job? Is their pattern very weird, or is it fairly regular? What is going on right here in front of me? What am I looking at? Next, the listen portion of all this is my patient able to speak regularly? Some people wind up so short of breath that they can only answer our questions 1 or 2 words at a time. And it's very short, like, yes, maybe, I don't know, things like that, because they don't have enough extra oxygen inside of them to speak to us. You know, is my patient altered? Is my patient unresponsive and unable to talk to me at all with a weird respiratory pattern that I found when I was looking? The feel portion, a couple of things. When we checked for a pulse during cardiac arrest management, we put our fingers on the carotid pulse and we checked breathing at the exact same time with our hand on the patient's chest. We're feeling to see how much chest wall movement is there. Do I feel like their chest is expanding and contracting enough for them to adequately fill their lungs? And then we auscultate. One of you guys out there tell me, what spaces on my person am I listening for with my stethoscope when I'm auscultating lung sounds?
The mid-clavicular, the lower breast, and the mid-axillary.
Okay, you got it. Mid-clavicular above the breast, mid-clavicular below the breast, and then mid-axillary just above the last rib. And we're going to listen right side, left side, right side, left side, because we're trying to compare what those 2 lungs sound like against each other. And hopefully when we auscultate, we hear lung sounds that sound like not a whole bunch of much. When we heard those normal lung sounds on the dummy, it just sounded like air moving, because air is supposed to just pass sort of easily in and out of our respiratory system. It shouldn't make a whole lot of noise. It shouldn't sound like a whole bunch of much. And if we start to hear any of those lung sounds that we talked about, wheezes, crackles, or rhonchi particularly, we can equate that to a medical problem. Wheezes is going to tell me constriction. Wheezes a lot of the times, especially on exhalation, is going to tell me asthma. Crackles anywhere is going to tell me fluid. And rhonchi, that's that rumbly kind of gross chunky sound, is going to tell me that my patient has some sort of infectious process going on. And they're all going to point me down different sort of treatment routes to make sure that I'm appropriately addressing what it is that's actually going on with this patient. So when we talk in terms of adequacy of breathing, rate, rhythm, quality, and depth. So all of those things are going to be done in our primary assessment. When we evaluate my patient's breathing, I am going to decide within the first minute or so of meeting this perfect stranger whether I have determined that their breathing is adequate or not, just by looking at rate, rhythm, and quality and finding out, is their breathing noisy? Is their breathing work? Is their breathing painful? If I find a problem with any one of those things, it's going to tell me that my patient has got a questionable respiratory status. My treatment is going to be fairly simple for most respiratory patients. They're not getting enough oxygen, so I need to figure out why and get them some more. We're going to maintain an open airway. We're going to provide supplemental oxygen. If we do get to that point where we're drawing the line between someone who needs to be ventilated versus someone who just needs to be oxygenated, I draw that line and I either ventilate or oxygenate appropriately. If my patient is in respiratory failure and breathing has become so much work that they're starting to nod off while they're doing it, well, then I know it's time to switch to a BVM. If my patient is blue, I know it's time to switch to a BVM. If my patient's respiratory rate is just a little fast, but they're able to speak to me and complain and tell me all about their respiratory issues, they probably don't need me to ventilate them. We want to look at rate, rhythm, and quality and make sure that my patient doesn't have any real functional complaint that I can put my finger on and try and decide respiratory distress versus respiratory failure versus impending respiratory arrest. Because my patient who's falling asleep between breaths is getting ready to quit doing it altogether, so I ought to start ventilating now. Anybody remember our ventilatory rates when we're talking rescue breathing for an adult? It was one breath every how often?
3 to 5 seconds.
Go a little bit more.
5 to 6 seconds.
Every 5 to 6. And what I'll tell you is, and we'll work on this on Monday because everybody is amazed at how much it feels like you're doing absolutely nothing. Because 5 to 6 seconds seems like a lifetime when you know that you're breathing for somebody else. It's only 10 to 12 breaths a minute. If we were going to ventilate this little baby here, it'd be one breath every 2 to 3 seconds. We're looking for, 20 to 40 breaths a minute with a child because they are rate dependent. They don't have any extra, and we need to ventilate them faster because they breathe faster. So we'll talk a little bit about signs and symptoms now of inadequate breathing. We talked about hypoxia. We talked about inadequate ventilation and respiration. Now let's talk about problems. So my rate, when I look at that and I'm trying to decide if my patient is having respiratory distress or having some sort of respiratory issue, if my patient is breathing too slowly, what's going on with them? I'm not looking for what their medical problem is, but what kind of problems is this going to present to their body?
They're not taking in enough oxygen, so they're not going to get that good transfer to the alveoli.
You got it. If they're breathing too slowly, they're not getting in enough oxygen per minute, because we'll go right back to the fact that the body doesn't do anything additional just for kicks. It doesn't do things just to do things. So if 4 breaths a minute was enough for people to survive as human beings, we would all only breathe 4 times a minute. We wouldn't breathe that stereotypical 12 to 20. So if your patient's only breathing 4 times a minute, you need their respiratory rate to come up. You'll have to ventilate them. What about my patient who's breathing like 40 times a minute? What's not going on there?
They're probably exhaling the oxygen before they get the chance to actually diffuse it.
You got it, because if they're breathing 40 times a minute, what do you think about this? Do you think 40 times a minute they're getting that good chest rise and fall? They're getting that oxygen all the way down to those alveoli where it needs to be, and all that gas exchange is going to happen when their chest is barely moving with every one of those 40 breaths per minute?
No, they're not. They're not getting that good expansion and contraction. They're not taking in enough oxygen and letting out enough carbon dioxide.
You got it. And if we're not expanding that chest and getting those alveoli filled with oxygen, most of the gas that we take in stays in that dead space, stays in that 150 to 200 milliliters of space where not one thing of function actually happens. If we don't fill those alveoli with gas by getting a nice good chest expansion and getting all that gas down to the business end where it needs to be, all of it stays in somewhere that doesn't do us one lick of good, because our rate being so fast has caused a problem with our depth, which is going to cause a problem with our quality, because the quality of breathing at that point is shallow and the depth is shallow and the rate is too fast, and none of the oxygen is getting to where it needs to be to actually cause anything of function to go on. No gas exchange, no byproduct removal, no aerobic metabolism, lots of other bad things downstream. So if we have a problem with rate, rhythm, quality, depth, or any combination thereof, we have found inadequate breathing. That is, there's a period at the end of that. Now, whether or not we're going to ventilate this patient or whether or not they're going to do well with just a little bit of additional supplemental oxygen is going to be based on your patient assessment. You know, how hypoxic are they? Are they still in those beginning stages where we found them pale, cool, and diaphoretic? Are they still breathing fast but able to talk to me? Or are they now so altered that they're nodding off between breaths and they're unable to speak to me, or they can't answer my questions, or their respiratory rate now has become so fast that they're not getting that good chest wall expansion, they're not getting those alveoli full, and my patient's starting to turn blue. My patient who's deeper into this whole problem is not going to get better from just me providing some supplemental oxygen to them, and I'm going to need to ventilate them with a BVM. Treat aggressively, especially when it comes to something like that, because the worst thing that's going to happen is your patient isn't going to allow you to ventilate them. If they still have enough pep in them to keep you from ventilating them and push the mask away from you, then guess what? They're still in the battle and they're probably going to do better than we think they are. And sooner rather than later, if they are truly in respiratory failure, they're not going to have the ability to fight you anymore on the mask. They're just going to relax and let you ventilate them. And you'll actually be able to watch them get a little bit better and get a little bit better. And it's all just based on using the senses that God gave you, right? Look, listen, feel, listen again when we get our stethoscope out, and figure out what stage of the game is this patient in. You know, how sick are they? Do they need me to actually now physically take over something their body is supposed to do on its own? Or are they doing it well enough that just a little support will get them out of the woods and get us to the emergency room? Little from column A, little from column B doesn't make any difference. We just need to start looking at every single patient that way. We do an assessment regimented, and we do an assessment the exact same way on every single person, because that prevents us from ever being able to miss anything. You know, guys that have been around even longer than I have stood in front of a classroom and said, I still do the same patient assessment that I learned back in 1991 when I took my first EMT class. And as long as you do the same thing the same way every single time, you're going to put the pieces together, and you'll be able to see, hey, this patient's got some respiratory distress. It looks like they're breathing too fast. But that big dummy that taught my EMT class said, unless they're blue, we can start off with some supplemental oxygen. So we'll start off with some supplemental oxygen and see if they get better. If they continue to get worse, then I'll break out the BVM. Or that big dummy that taught my EMT class told me when people are blue, it's a bad thing, and I should probably ventilate this patient with a BVM. I'm happy to be that guy in either scenario. How was that?
Good.
Good, helpful.
Did we clear up anything, or did we make the waters muddier?
Good.
Is anybody more confused than they were?
No,
Was that a yes or a no?
that was a no, not
That was
confused.
a no. Okay, good. Because I'm really flunking at my job here if we finish a lecture and everybody goes, now I'm more messed up than I was when I sat down. That's awesome. All right, before we get into pharmacology, we're going to take another break. This is not as difficult or as lengthy of a lecture as what we just finished up. So that should make you guys kind of happy, because we're in the beginning of this program, we get all of the real difficult stuff out of the way early, and then we work on it the entire rest of the time. So don't be disheartened if some of this stuff still seems hard and still seems like a foreign language. I promise we'll be speaking it by the end of the month. All right, it's break time. All right, everybody, we are back and up and running. So now we're going to talk about some principles of pharmacology. And one of the things I stress all the time when we talk about pharmacology and administering medications is once you give that medication, you can't take it back. So once you have administered a drug, any drug, it's for keeps. There's no ability to be like, oh, that was a mistake. I shouldn't have done that. So that's why it's important for us to learn the ins and the outs of all the stuff that we're going to be responsible for as far as medications go at the level of our certification. So the package that I handed out to you guys yesterday, I know I didn't get a chance to go over it, are all of your BLS medication protocols, and really they are mostly standing orders. If we go all the way back to our first lecture and we talk about standing orders, these are medicines that you're allowed to provide to a patient without, for the most part, talking to anyone, period. That's why it's important to be right. And if you ever have any question about whether you're right or you're wrong, you pick up the phone, you call medical control, you talk about it with your partner, you figure out, should I do this? Or should I not do this? Because just because we can doesn't always mean that we should. So we can administer meds, we can assist with meds. The administration of a medicine is to take a medicine that is in my control and actually introduce it into the patient. Could be orally, it could be intramuscular injection, it could be inhaled, but this is a medicine that I have, through my assessment, figured out that this patient meets the criteria to receive, and I am going to administer this drug to them. If I'm going to assist with a medication, something like nitroglycerin. Nitroglycerin we can help a patient take, but nitroglycerin is not a medicine that we're going to carry on our BLS ambulances. Only the patient's prescription nitro that we're going to assist them with. We need to make sure that we're up to snuff on the procedures of giving the medicine. We want to make sure that we're up to snuff on our indications and our contraindications. An indication is a reason why you should give a drug, a contraindication, a reason why you should not give the drug. And we'll talk about medical control sort of throughout all of this. A drug is any chemical that we're going to introduce into a person to treat a disease or condition. Pharmacology, if you want to get into the definition thereof, it is the study of everything drugs. Now, for one, I had no idea pharmacology was as involved as it really is at a whole. My oldest son is actually in his third year to become a doctorate in pharmacology. And the stuff that they're making this poor kid learn is just mind-boggling. There is so much that goes into medication, probably more than we could spend the whole next month talking about, even at a basic level. But we really just need to know the drugs that we're going to give and the reasons why and the reasons why not. We'll talk at length when we get into talking about cardiology and talking about respiratory and talking about immunological disorders as to how the drug does what it does, why the drug does what it does. Today, we're really just looking at the drug itself, and we're going to talk a little bit more about what is actually going on and sort of the why we're giving it. Because medications have specific effects on the body. I know when I give my anaphylaxis patient, my severe allergic reaction patient, an injection of epinephrine, that there are a lot of things that epinephrine is going to cause to happen inside of that person. When we talked about stress reaction, and we talked about epinephrine being responsible for that whole fight or flight and causing a whole bunch of stuff inside of us when we're faced with a stressful situation. Epinephrine does all the exact same things inside of your patient when you deliver that drug So those are things that we need to be prepared for. We need to be prepared for a patient whose blood pressure is going to increase, whose heart rate is going to increase, whose respiratory rate is going to increase, because those are things that we know that that medicine does. When we correctly administer a medication, we may actually get to see the patient's condition improve significantly right there in front of us. We may also give a medicine appropriately and see next to no change at all in our patient's condition. It depends on how sick they are. But what I will tell you is inappropriately delivered and inappropriately delivered medicine is going to make your patient worse. When we talk about pharmacology and we talk about getting ready to deliver a medicine to a patient, there are 6 patient rights we need to think about. We need to make sure we have the right patient. We need to make sure that we've done our assessment and through our assessment decided that this patient does meet the criteria to receive this medicine. This is in fact the right patient. We need to make sure that we have the right dose. Epinephrine for us comes in 2 different doses. We have an adult dose, we have a pediatric dose. We need to make sure that we know what our protocol dictates as to who gets the adult dose and who gets the pediatric dose. Because if you were to inadvertently give an adult dose to a pediatric patient, you would be significantly overdosing that person. And vice versa. If you gave a pediatric dose of a medicine to an adult patient, you would be way underdosing them, and the consequences could be severe. We have the right patient, the right dose, the right route. When we give a patient aspirin, for example, we tell them to chew those aspirin up, not to just swallow them. We tell them to chew the aspirin up because it turns it into a powder, and when it gets to their stomach, it gets into their bloodstream faster. If you get a migraine or a headache or have, knee or back pain or something, when you take an 800 milligram Motrin for it, it doesn't start working right away, because when that pill in pill form hits your stomach, it takes about a half an hour to start working. If I'm giving aspirin to somebody who's having chest pain, I want that aspirin to start working right this very minute. So we got right patient, right dose, right route, right time. For our intents and purposes, right time means I have done my assessment, I've gotten the other rights out of the way, I have a current and valid set of vital signs so that I make sure that my patient is well enough to receive this medicine. Right indications, that's just me double checking my work again. I want to make sure that the condition that I know this medicine is used to treat is the one that I'm looking at in front of me. And then the last one is to protect you. In the communications and documentation portion of the book, it talks about properly documenting your medication administration. Because if you didn't write it down, it didn't happen. So if you didn't go through all those other steps prior to saying I'm going to deliver a medicine and then delivering that medicine, it's as good as not doing it and just running around handing out EpiPens and sticking people all which ways but straight. We need to make sure when we're going to give a drug that we are dotting our I's and crossing our T's, because our protocols, which is our offline medical direction, our standing orders, lay this stuff out for us really pretty simply. It's you do your assessment, and if your patient falls into this category, they get this medicine. It tells us the dose we're going to give. We don't have to do any real particularly deep drug math or anything like that that really gets out of control fast. We just need to make sure that we are giving this its due diligence, because giving the wrong medicine can really have some pretty gnarly, pretty nasty consequences for both your patient and you. We have to know our local protocols. I printed out that protocol sheet for you guys because trying to read the protocols the way the state puts them out is like trying to read the dictionary. Things wind up in weird places. They reference one another. I just cut out the middleman and copy and pasted the highlights because we really need to get good at the drugs that we're going to be contacted with.
Tommy,
Yo,
was there something on here you wanted us to cross out?
there is. Give me 1 second because I don't have one of those in front of me, so I'll pull it up and tell you what you don't need.
Okay.
So in our protocols, because someday I'm sure you'll need to look at them. Every once in a while, we still refer to them. Anything that is green, marked emergency medical technician, is going to be with the playbook we're using. But that also means that we can also do any of the first responder things. So green and blue is the orders for us. Anything that's marked advanced or paramedic is stuff that we're not going to touch, things that we're not going to do. So if it's outside of your scope of practice, it's going to be here or it's going to be here. It'll either be yellow or red. We just need to concentrate on these two areas right here. If we're looking at our protocol and we want to give somebody a medicine and we see this symbol right here, what do you think that means?
Maybe an allergy or something.
So close. You see one of those caution red flag warnings and it says, stop, wait a minute, make sure you figured this out appropriately. That is a wait a minute, this could be bad. So there's all sorts of places in there where we'll have one of these caution flags, or even a bit more serious, a telephone. Because most of the drugs that we're going to be able to give, we can give without picking up the phone. If you see in your protocol there is a telephone next to what it is that you want to do, that means, again, stop what you are doing and pick up the phone and talk to somebody first, because there are sort of some give and take in these. One of the big ones was always epinephrine. You know, we can use epinephrine for a couple of different things, and there are times where we would want to give epinephrine to a patient. If you look at the protocol sheets I gave you, one of the ones that it talks about in anaphylaxis for epinephrine administration is if my patient is over the age of 65. We don't just give epinephrine to patients over the age of 65 because people that have reached that stage in life sometimes have some high blood pressure issues or sometimes have some cardiac issues. And maybe if they have high blood pressure and some cardiac compromise, giving them epinephrine will actually make them worse and possibly kill them, as opposed to fixing their anaphylactic reaction. So we pick up the phone and chat it over with medical control, and they're going to tell us either, yes, please give them the epinephrine to correct their anaphylaxis, or no, that epinephrine may cause them to die, just transport them. And then whatever medical control says at that point, we do. And because children are not just small adults, when we see a teddy bear, that means this is pediatric specific. Not all the protocols are broken down into adult and pediatric. If you look up under first responder here, where you see 2.2A and 2.2P, 2.2A is the adult protocol for protocol 2.2. I can't quote these off the top of my head. So protocol 2.2P is the pediatric specific protocol for whatever protocol 2.2 is. I'll look it up in a second. Some protocols are just written as an adult protocol, but they have a pediatric component to it. So they didn't break it down as its own thing. They just have, you know, do this with pediatrics as opposed to doing whatever with an adult. They're pretty straightforward. Like I said, they just don't read like a book. That's why you guys have them in the form that you do. So here are our BLS stock medications. These are the ones that we are going to carry on our ambulance. We have oxygen, because oxygen is a drug, oxygen is a medication. We have baby aspirin. We have adult and junior epinephrine in an EpiPen or in an injectable, because you guys are actually Monday going to learn how to draw up and inject meds. We have glucose, nasal Narcan, and albuterol. Now, this albuterol is talking about nebulized albuterol. You know, anybody in the world that's ever been diagnosed with asthma has been given an albuterol inhaler. And we can assist with my patient's albuterol inhaler. That's that second bullet point right there. But we actually carry nebulizer equipment on the truck, and we can use our own albuterol liquid in the nebulizer to actually help an asthma patient more. Because most of the time when an asthma patient is having an asthma attack, they have probably already used this somewhere in the neighborhood of 50 times. And if their prescribed rescue albuterol inhaler was going to help them, it probably would have helped them, 48 uses ago. Sometimes asthma patients just get so sick that they can't breathe well enough to use that rescue inhaler. So we can use our equipment and our nebulized albuterol to actually now almost force that medicine into them. Because when you put albuterol through a nebulizer, it actually turns it into a mist. And as long as that mist is either in their face in the form of a mask or in that little peace pipe thing, if anybody's ever seen the nebulizer, that little pipe that they have, as long as they are breathing through our equipment, they will be receiving albuterol and it will help their respiratory problem. We'll hear their wheezes start to get a little better. We'll see their respiratory rate, rhythm, and quality start to improve. And our patient won't have as much in the way of complaint of respiratory distress. And then the last thing we can assist with here is our nitroglycerin. Remember, nitroglycerin is not a medication that we're going to carry. Nitroglycerin is a medicine that is very patient specific. If you give nitroglycerin to the wrong patient instead of what we see right here, the right patient, it is entirely possible that they won't see any more sunrises. Nitroglycerin can be a dangerous med if we use it outside of our protocol and use it outside of what we know to be right. So here's our 6 patient rights again. We have the right patient, the right med, the right dose, the right time, the right route, and the right documentation. We need to make sure all these things are lined up, because just always keep it in the back of your mind. Once that medicine leaves you, it's in the wind. There's no ability to get that back. So messing that up is not a good thing. So here we go. We're going to talk protocol a little bit here. We're going to talk indications, contraindications. We are going to go over these meds that we can deliver right now. So you heard me hop on my soapbox a little bit about oxygen. For forever and a day, we have just been over-oxygenating people. Oxygen, when I got my EMT certification, and even up until recently, was, oh, that's harmless. Some oxygen is good, more oxygen is better. Put 2, 3, 4 non-rebreather masks on them and give them as much oxygen as humanly possible. And then science happened. Now, as far as actually physically treating a patient goes, I only want you, when you're working in the field, to give oxygen to people who need it. If your patient is in respiratory distress or has any form of respiratory complaint or looks like they're having some difficulty breathing, we're going to give them oxygen. But just because your patient has a headache or chest pain is not a reason to give them oxygen. Unless they're having a headache and chest pain and trouble breathing, hyperoxygenation will actually make strokes worse, it will make heart attacks worse, and it will really cause all sorts of issues for this patient after our interaction with them. And I don't know about you guys, but I wouldn't be showing up in an ambulance if I was looking to make people's lives more difficult. Are signs and symptoms of someone who needs oxygen, so hypoxemia, low oxygen in the blood, there it is again, shortness of breath or respiratory distress, rapid breathing, fast heart rate, or signs of poor perfusion. What am I talking about when I say signs of poor perfusion?
Could be talking about how their skin feels, if they're cool or clammy, or if you see any cyanosis.
Perfect. Would I want to see cyanosis first or one of the other ones?
Probably want to see how their skin is first.
Yeah, because cyanosis, is that an early sign or is that a late one?
That's later on.
Yeah, the one that we're hoping to see first is pale. So I look at my skin signs, my skin color, temperature, and condition, and that's going to tell me, is my patient perfusing well, or is my patient's perfusion status kind of crummy? So if I see these things, even if my patient doesn't complain of necessarily shortness of breath, or I can't break out my little handy dandy pulse oximeter and see, is my patient short of breath, or have a low O2 saturation, because that's what we hinge it on right here. The American Heart Association said an SpO2 or pulse oximetry reading of less than 94%. Then we want to give them oxygen. And years ago, we used to, everybody got non-rebreather mask, 10 to 15 liters per minute, no questions asked. But if we are trying to treat somebody with a medicine, should we always give them as much medicine as we can?
No.
No, you want to start out low and work high. So now, when you are treating patients in the field, if your patient needs oxygen, start small. Start with a nasal cannula and give them, 1, 2, 4, something like that, liters per minute, all the way up to 6. And if they're not getting better, then we start thinking about, does my patient need the high flow, high concentration O2 that a non-rebreather can deliver? But if I start up here with a non-rebreather mask, I don't ever know if a nasal cannula would have been enough. And I'm taking a chance at hyperoxygenating this person. Now, when we talk about pulse oximetry, and we're going to do a lecture on vital signs coming up next week, pulse oximetry is one of the most unreliable pieces of equipment that I could ever talk to you about, because it's a little beam of light that measures how much hemoglobin has something on it. Hemoglobin's meant to transport oxygen to the cells, right? We already covered that pretty heavy for the last couple days. Pulse oximetry doesn't measure how much oxygen is on hemoglobin. Pulse oximetry just measures how much something is on the hemoglobin to be transported. So things like cyanide poisoning or carbon monoxide poisoning, those poisons all bind to hemoglobin better than oxygen does. So you could take your little pulse oximetry probe, stick it on your patient's finger, and guess what? They could be dead in front of you and have a pulse oximetry reading of above 94%. If they were dead, do you think they needed oxygen? Anybody?
I mean, yes, but they
Yeah,
also
I
need.
would say so, right?
Yeah.
So pay attention to your assessment. Don't always fall back on, well, my machine's telling me this, because we're treating people, we're treating patients, not treating machines. So if you use your pulse oximeter and you can see your patient struggling to breathe, and your pulse oximetry reading is showing you as 96%. Now we know 94 is the cutoff, but my machine's telling me 96. Looking at my patient is telling me my patient is short of breath and distressed. Do you give that patient oxygen? Which one's right, the machine or the patient?
Probably patient.
Yeah, the patient, always. Machines, especially this one in question, this is one of the really only, and I know we talked about it a little bit. Somebody asked about automatic blood pressure machines and all that stuff too. Your machinery can fail you. Your ability to assess a patient never will. It's just not going to, because you are looking for the things that tell you, hey, this patient is sick. They're not hiding. You're just gonna, you have to find them. It's like playing Where's Waldo? Where's the sick person? So now we're out of that because oxygen. Ugh. Let's talk about aspirin. We give aspirin to chest pain patients. We give aspirin to people we think may be having some form of cardiac event. We do not give aspirin to people who have sustained a traumatic event causing their chest pain. So there's our defining line. People who are having chest pain just sitting in their living room minding their own business, we're going to give them 4 81 milligram baby aspirin to chew, which is 324 milligrams. Does anybody know why we give aspirin to people we think are having a cardiac event?
Because it's a blood thinner.
Yeah, we'll go with that for a minute. It's not so much that it's a blood thinner. Like when you think about blood thinners, you think about things like heparin and Coumadin and a couple of the other ones that have commercials on daytime TV. What aspirin is actually doing is it's going into the bloodstream and it's making the platelets less sticky. Platelets are what causes blood to clot. Now, if I lost an argument with a chainsaw and half of my arm was cut off, I would want my blood to clot. So I wouldn't want anybody giving me any aspirin. But if I had a blockage in one of my coronary arteries, I would chew up that 324 milligrams of aspirin, trying to make those clots less sticky. Because if I have a blood clot in a coronary artery, and those platelets keep showing up and sticking together and sticking together and sticking together and clogging up that artery more, my heart attack is going to get worse. If those platelets lose their ability to stick together and make that clot bigger, there's still a possibility that some blood will get by the blockage in that artery. Therefore, I'll still be able to perfuse that bit of heart muscle, oxygen still being delivered, carbon dioxide still being removed, aerobic metabolism is still happening, and that tissue in my heart isn't actually dying. It's still causing me pain because it's still cranky and it still isn't a big fan of what's going on, but just chewing up 324 milligrams of aspirin may actually prevent me from having a true myocardial infarction. So when we give a patient these 324 milligrams of aspirin to chew, their chest pain isn't going to get better. They're still going to have the exact same amount of chest pain they did when we gave them this aspirin. But what we're looking for are now the downstream events. I gave them this aspirin. The clots aren't, the platelets aren't going to be as sticky. If the platelets aren't as sticky, the clot's not going to get any bigger. The artery's not going to get any more blocked. And maybe we can prevent any real long-lasting damage. Aspirin's an important medicine to someone we think is having a cardiac event. Our contraindications for aspirin are GI bleeding or allergies. Remember, if somebody's got a significant bleed going on, GI stands for gastrointestinal. So this is our patient who's either vomiting blood or pooping blood. If they have a significant internal hemorrhage going on, we don't want to interfere with the body's ability to clot, because those GI bleeds, I'll tell you, can lead to bleeding to death in a hurry. So how would we figure out whether our patient had any GI bleeding going on?
If they're conscious, you can ask them.
Shot in the dark, asking them and palpating.
So not even so much palpating. You were spot on when you said, I don't know, ask them. Absolutely. When we're doing an assessment of a medical patient, most of what we're doing with that patient is really just talking to them and peppering them with questions, because that's how we get to the bottom of not only their medical history in general, but their history of their present illness. What is going on right this second? So really, we just ask them, hey, part of our medical assessment is to ask them the last time they had anything to eat or drink and the last time they used the restroom, was it normal? It seems like a weird question, but it's a pretty straightforward question when you start thinking about what we can actually use to treat this person. And then allergies is another sticking point for baby aspirin. Most people, when they say they're allergic to aspirin, it's not really a true allergy. They say, oh, I take aspirin and I get an upset belly. If your patient says they have an allergy to the medication that you're trying to give them, well, you can't give it to them anymore. So at that point, we don't give them any aspirin if they say they're allergic to it. Next, we're moving on to EpiPen. Who gets an EpiPen? Does anybody know?
Patients who are having allergic reaction.
Anaphylactic,
Yeah.
Is it anaphylactic shock? Is that what it is?
Anaphylactic shock, allergic reaction, I'll take both of them. Anybody out there have any type of allergy that they need an EpiPen for? Bee stings, peanuts, anything like that? Okay, fair enough. What I'll tell you is, when you give a patient an EpiPen, this is one of the real for life legitimate times that you will actually witness yourself save someone's life. Epinephrine takes all of the bad stuff that's happening during that anaphylactic shock and reverses it, all of it. Anaphylaxis is one of those times where your patient's body is trying to kill them on a number of fronts. It is really taking out airway, breathing, circulation, and everything else. Anaphylaxis is the real deal. Our patient's blood pressure goes down, their vasculature decreases, their airway constricts. We have all sorts of leaking and all sorts of fluid everywhere. Airway, breathing, and circulation are really under attack when we have a patient in anaphylaxis. Our adult dose of epinephrine is 0.3 milligrams IM. IM stands for intermuscular. We can repeat it after 5 minutes, and here's our indications for it. So first we see stridor. Stridor, we already talked about today, is an airway that should be beyond scary. The airway starts to swell, the airway starts to constrict, and the airway may well close if the swelling and constriction gets any worse. Bronchospasm. Bronchospasm is the spasming of those smooth muscles that are around our alveoli and around our bronchioles. That spasming constricts the lower portion of the airway. So now we have upper airway constriction, we have lower airway constriction. We'll skip over abdominal pain for just a second. We have respiratory distress, tachycardia, a patient who looks like shock, and then we have the oropharynx and the hypopharynx and the tongue and all the mucous membranes starting to swell. Does this sound like a patient who passes our airway assessment?
No.
Does this sound like a patient who passes our breathing assessment?
No.
Signs and symptoms of hypoperfusion, shock right here. Does this sound like a patient who passes our circulatory assessment?
No.
Nope, dying, right in front of you dying. And then that severe abdominal pain. Does that look like a weird one to be on this list?
Yes.
All right. Severe abdominal pain makes it to the list because when the body is in a state of shock, and fighting just to perfuse all the important stuff, it says, hey, all the stuff that's really not altogether that important isn't getting any blood right now, so you can like it or you can lump it, but that's the way it's going to be. So we start to pull blood towards the important things, and we start to shut off things like the gastrointestinal tract, which requires a huge blood supply. The entire bit of our GI tract, if we took it out and stretched it, it would be as tall as a 3-story building, surrounded by vasculature. So the body goes, you know what? I don't care if you need to digest lunch right now. We are trying not to croak. And it shuts off that blood supply to the GI tract. And your patient will wind up with bubble gut and some severe abdominal pain and cramping, nausea, vomiting, diarrhea. All of these things are really the body's last ditch effort at trying to keep homeostasis, which is that nice flat level that the body likes everything to be at, trying to fight through shock, and trying to complete perfusion. We need to keep that happening. Epinephrine is going to fix every last one of those, every single one. It reverses the bronchospasm. It constricts that swelling, so the stridor goes away. It fixes the abdominal pain. It fixes the respiratory distress by opening now the lower airways back up. The tachycardia might get worse for a minute because epi's going to crank their heart rate up, but it fixes shock. It fixes all that swelling because it goes in and constricts down all of that stuff that just went wild and out of control. But since it causes so much constriction and so much stress and strain on the vascular system and the heart, that's why we don't give it to people over the age of 65 until we call medical control. Because by changing the way their heart's working and changing the way their vascular system's working, we could really cause some negative things. That's why we need to talk it over with a doc and let them make the decision. Next on our list, we're going to talk about junior epinephrine. Junior epi is given for all the exact same reasons. It is given for all the exact same things that we're going to see. It is given for all the exact same causes of anaphylaxis, but we give half the dose. For our pediatric patient, we are going to give 0.15 milligrams of intramuscular epi for a patient who is less than 25 kilos. Now, 25 kilos is roughly 60 pounds. What I'll tell you is if your patient is a skinny little twig of a kid, he probably gets the junior epi. If you're looking at a chubby kid, he gets the adult epi, the 0.3. If you think your patient is over 60 pounds, give them the adult dose. Your best bet would be to ask mom or dad because they're going to be able to tell you roughly about what the kid weighs. If you need to give a second follow-up dose of epinephrine to a pediatric patient because their symptoms have either persisted or gotten worse, you need to call medical control. Generally, the initial dose should be enough, but if you need to give a second one, we have to get on the phone with the doc first. We also need to call medical control if our patient is under the age of 6 months. We don't give epinephrine to people under the age of 6 months because kids that young are generally still protected by immunity that they received from mom when they were in utero and shortly after birth. Not only that, true anaphylactic reactions don't happen until the second time your body is exposed to something. The first time you get exposed to something, you may have a reaction that's called anaphylactoid. It's your body's immune system priming and getting ready. And then the next time you get exposed to something, your immune system freaks out and tries to murder you. That's the way anaphylaxis works. It is an immune response, something your body does every single day. Your immune system decides whether something is self or not self. If it's not self, it's termed an invader. If it's an invader, the immune system kills it. With anaphylaxis, the immune system identifies that invader and tries to kill itself.
Now, is anaphylaxis something that typically takes a long time to happen? So someone has allergies for their life, then gets worse, or is that something that can just come on within like minutes of?
Both. A lot of times, if it's food or a medication, since people take that by mouth, then it takes a little bit of time because it has to break down in your stomach. If it's something injected like a bee sting, or even the oil or dust from a peanut, that can be minutes, seconds, almost immediate. Because once something's injected into you or absorbed through the mucous membranes, it's in the bloodstream already.
Oh wow, okay.
So food a lot of the times will take a little bit of time just because it needs to be broken down and digested a little first. Other stuff can be almost immediate.
Okay, thanks.
Yep. So oral glucose. Who all are we going to give oral glucose to?
Diabetes patient.
Diabetes.
Yeah, somebody who's got diabetes. Our dosing for oral glucose is going to be 1 tube. We have to check the patient's blood sugar first. This is another one of those ones for me that I always laughed at. When I first got my EMT certification, we were not allowed to check blood sugars on a BLS ambulance. It was considered an advanced skill and only advanced level providers could do it. You could take a 4-year-old to the Jocelyn Clinic and they would teach a 4-year-old how to check their blood sugar. But EMTs were not allowed to do this. So if we found a diabetic patient with a history of diabetes who had an altered mental status, we gave them sugar whether their blood sugar was 40 or 440, because again, some is good, more is better. Now we actually science. And in doing that, we check our patient's blood glucose. It's a simple process. It's another one of the vital signs that we'll talk about within the next week or so. And checking their blood glucose is going to give me a definitive number. There is no shortage of information that will tell me if my patient's blood sugar is less than 70, their blood sugar is going to be low and the brain is not going to function appropriately. So my indications for glucose administration is a confirmed blood sugar of 70 or less, or below 70, don't say 70 or less, below 70, and symptomatic. Symptomatic is going to be anything from altered mental status to just not feeling well to just about anything, because every cell in your body wants to have sugar. That's how they make energy. One of the things that we need to make sure is that our patient is able to swallow and speak and follow our commands. Why wouldn't we want to give oral glucose to somebody who could speak to us and swallow and follow our instructions?
They could choke on it.
Yeah, we're going to create an airway problem. And we don't need any additional issues. If my patient is so altered from low blood sugar that they can't follow my instructions and be relied upon to protect their own airway, we have no business giving them this medicine. I worked with a guy not too long ago, actually, and he got dispatched in the middle of the night to a nursing home for a cardiac arrest. And when he got there, as he went to intubate this patient, because he was a paramedic, he opened her airway, and when he looked in, her airway was filled with grape jelly. So before he could intubate her, he had to suction. Then he went back, intubated the patient, and he asked the nurse in the nursing home why her airway was filled with grape jelly. And as the story unfolded, the patient went into cardiac arrest because her blood sugar was next to 0. She couldn't speak, couldn't swallow, couldn't follow instructions, so they poured grape jelly in her mouth. And then the patient coded and died. So this is really important stuff. If your patient can't protect their own airway, not only do we have to protect it for them, We don't have any business giving them things like oral glucose or anything else by mouth. So this is one we'll be intimately familiar with. We'll talk about this at length. We'll work on this. I know it seems weird that we're going to ventilate a patient for 3 to 5 minutes first before we're going to give our first dose of Narcan. But keep in mind, someone probably already Narcaned this patient before you got there. Someone probably wasn't ventilating this patient before you got there. And we don't want to go just dumping as much Narcan into patients as humanly possible, because that's how we wind up with an angry, withdrawing drug addict who is a vomit sprinkler and wants to fight with everyone. Riddle me this: which one of these two things sounds better? The patient I just described, or the patient who's a little drowsy, breathing somewhere around 10 or 12 times a minute, and you just need to give them a little rustle to wake them up?
The guy that's a little drowsy.
The guy that's a little drowsy. So don't just keep dumping Narcan into patients. If you're going to give somebody a lot of something and you suspect that they've overdosed on an opiate, give them a lot of ventilations. You have to give that Narcan some chance to work. You have to give this whole thing a few minutes to unfold. And those 3 to 5 minutes of ventilation is going to oxygenate their brain. We want them to wake up a normal human being. I would much prefer someone who was still a little sleepy, who I had to poke every once in a while to get them to answer my questions, rather than someone who was trying to throw up on me and wanting to fight. So, albuterol. We are going to talk about this Monday. We are going to get into albuterol at great length, because I don't want to go over the nebulizer protocol with you and make something not confusing more confusing. So we're going to skip over that, because for all intents and purposes right now, I want you guys to just understand that if your patient has their own inhaler, you may assist them with it as long as they haven't reached their maximum dose. They're probably not going to know what their maximum dose is. They may or may not have used their inhaler 1,000 times before you got there. But if they tell you, no, I haven't used it, go ahead and help them with it. We'll talk about the actual how of using that inhaler when you come into class on Monday. I'll put that on my list of things to be done. And the last thing we're going to talk about, this is our final assisted medicine, is nitroglycerin. When we're treating somebody for cardiac-related chest pain, we already know we're going to give them aspirin. Anybody remember how much?
324 to 325 milligrams.
Yep. And what am I going to tell them to do with it before it
Chew
goes
it.
down the gullet?
Chew
You
it.
got it. 324 to 325 milligrams of aspirin chewed. Patients who have a prescription for nitroglycerin and are having chest pain are also going to receive aspirin. You're going to give them both. They're going to get aspirin and they're going to get nitroglycerin. Nitroglycerin, different from aspirin, is actually trying to help this patient right now. Nitroglycerin will actually improve their chest pain. Nitroglycerin takes those arteries that are clogged and vasodilates. Nitroglycerin actually dilates our vascular system so that now more blood can get by wherever that clot was. Look at how teeny tiny that pill is. And that little pill will do all of that. It reduces the amount of oxygen the heart's going to demand. It decreases the cardiac workflow. It dilates those coronary arteries so that some blood can get by and we'll get more perfusion to those pieces of the heart. And it makes the patient feel a little bit better. It actually improves their chest pain. But when we give nitro, we also have to know that it's a vasodilator. And what happens to the pressure in the tank if I increase the size of the tank, but not the amount of fluid?
Pressure drops.
The pressure drops. So if your patient's blood pressure isn't at least 120 systolic, you can't give them any nitro, because nitro may cause such a significant drop in that patient's blood pressure that we could kill them or make them go unresponsive. So this is an assisted medication, so it has to be the patient's own. We have to assist them with their own pills. We don't carry this. We can give a total of 3 doses, counting the amount that the patient took before we arrived. We're going to give the first dose after we get our systolic blood pressure and make sure it's above 120. Then we're going to reassess our patient because we provided them a medicine. We need to see if it's working. We'll ask our patient, hey, has your chest pain improved any? We'll take another blood pressure. If my blood pressure has fallen below 120, I can't give another nitro. If my patient's blood pressure is still above 120 and they are symptomatic, so they are still having chest pain, I can give them another nitro. And then I wait. After 5 minutes, I'm going to reassess them again. Hey, are you still having chest pain? Did that help any? If they say it helped, but I'm still having chest pain, I check their blood pressure again. If it's above 120, they get their 3rd tablet of nitro. If it's not, they don't get any more nitro. So you can give a total of 3 doses, 5 minutes in between each, as long as their systolic blood pressure stays above 120.
Tommy, question.
Yo.
How long should we wait after the first dose to check their blood pressure again?
So it's still in that 5-minute window. So you give the first pill, wait 5 minutes, check. Give the second pill, wait 5 minutes, check. Give the third pill. So all in all, it should take somewhere in the ballpark of about 10 minutes to give all 3 doses. So here's our contraindications for nitroglycerin. If their systolic blood pressure is below 120, okay, that's no big deal. If the patient does not have their own, we're not going to go take in their maiden Aunt Sally's nitro. We're not going to go to the nitro ferry. Nitroglycerin can kill people who shouldn't be taking it, so it is a terrible idea. If the patient has already taken their maximum dose, if the patient has taken 3 and not getting any better, do you think 35 of these things is going to make that patient any better?
No, definitely not.
Yeah, so we stop. If 3's not doing the trick, we know that this isn't working. We need to just transport them to the emergency room. Don't just keep dumping nitro into them. 3 is our total dose. Now, I know somebody out there probably has already read chapter 11 in the book. And if you haven't, you will. And you'll see that the number that the book gives you for a systolic blood pressure is less than 120. The book tells you, I think, 100 systolic. Unfortunately, Massachusetts can't get with the times, and we always have to be different. The national curriculum says systolic blood pressure of 100 or follow your local protocol. If you're in class here, tell me that the patient's blood pressure needs to be 120 in order for you to give nitro, okay? If you are sitting in front of your computer taking a test, the number is 100. I know that sucks, but that's just the way the wonderful people at OEMS love to do some stuff. Did that make sense?
It does. One question on top of that.
Mm-hmm.
So depending upon the test we take, on the NREMT, it would obviously be what the book says, the 100, but on our mass testing, something like the test we're taking this weekend, would it be 120 or 100?
No, it'd still be 100.
Okay.
All of the computer-based stuff is national curriculum. All of the in-person stuff is Massachusetts wild and wacky world of making things up.
All right, thank you.
Yep. And the last thing we need to look at as far as can I give this patient nitro or can I not give this patient nitro is a couple of drugs that are pretty specific vasodilators. all of those erectile dysfunction meds, Viagra, Levitra, Cialis, any of the knockoffs of them, they are vasodilators as well, except they only dilate specific vasculature. Nitro is a vasodilator that dilates everything. So if your patient has taken an erectile dysfunction med within the last 48 hours, don't give them any nitro. When those types of medicines get into the patient with a nitroglycerin, they actually feed off of one another, and they cause even more vascular dilation. And that vascular dilation will take the patient's blood pressure to a point where it is no longer maintainable, and it will send the patient into cardiac arrest. So if you ask your patient about what they take for medications and you're thinking that they might need a nitroglycerin, if they tell you that they've taken one of these ED meds, make sure they know that it can't have been within the last 2 days. And if it was and they're not telling the truth, that they'll die, because they will be all kinds of dead and there'll be nothing you'll be able to do about it. And that's a wrap.
Quick question on that last slide.
Yep.
Is the 48 hours from taking any ED medication another Massachusetts specific thing? I believe the
No,
text.
no, that's legitimate.
Okay.
Yeah,
One more
actually,
question.
Viagra was initially made for a cardiac med. It just turned out that it had a much more marketable side effect. Somebody else had a question?
Yeah. I'm not sure if you said this, but if a person is hypoglycemic and can't take the oral glucose, would we hit them with an EpiPen or?
No, Epi's only for anaphylaxis, and if they can't take the oral glucose, you can do two things. The first is going to be transport, and the other is going to be try to meet up with a paramedic intercept, because they can actually start an IV and give sugar through the IV, and that will reverse the patient's hypoglycemia. All right, anybody else? Well, on that note, I have 11:42, and you guys will be in the care of Kevin and Will this afternoon. I'll be back Monday morning. And off topic, weird question. Did anybody lose a handcuff key in the classroom yesterday?
That's probably me.
Yeah, it's on my desk. I thought it was probably you. But
Should not be answering that while being recorded.
so it's on my desk by the keyboard. Just swing by and grab it if I'm not here when you get here.
All right, thank you.